Oh, okay.
Sorry, I just set the recording for our webinar.
Oh, okay.
Let me go ahead and give you control so we have that all set up.
Okay. All right, let me just try it. So what do I do? Just enter, right?
Yeah, one sec. There you go. Now you should have control.
Okay. Am I just entering?
You're moving the mouse, so I see it going.
My control panel. I don't have any.
There you go. There you go.
Oh, there we go. All right. Trigger finger. Okay. I think we're going back the way. There we go.
Perfect.
Just put all this on hold.
All right, we'll give everyone probably about 5 to 6 more minutes to log on. So.
Okay.
Good afternoon, everyone, and welcome to the American Heart Association Southwest Affiliates webinar titled Stroke Essentials, Together to End Stroke, Ideas for Stroke Community Education. The American Heart Association is proud to offer a suite of quality improvement programs that can help you advance farther and faster in your quest for better quality improvement. You can see our first slide shows many of our programs and the site to visit for more information, heart.org/quality. Today's webinar is the third in a series of offerings focusing on essentials of stroke care. We will be calling upon experts in our Texas primary and comprehensive stroke centers to share their knowledge with professionals who are new to stroke or professionals in smaller facilities where staff handle time-critical diagnoses. We will meet the fourth Tuesday of each month from 12 to 1 p.m. If you would like a topic to be covered in this series, please let your local quality improvement director know. If you don't know who your quality improvement director is yet, we will provide contact information at the end of today's webinar. Before we get started, I'd like to go over a few housekeeping items. We ask that you place all of your phones on mute by hitting *6. This will cut down on background noise for us so that we're all able to hear our speaker. Thank you. And to come off mute, again, it would be *6 to come off mute if you have any questions today. You can also use the questions section of GoToMeeting to submit your questions. All slides and handouts will be sent to all of you attendees within a week of today's call. Also, feel free to visit heart.org/SWA-quality for our audio recording for today. At this time, I would like to turn it over to Kate Simpson, the Director of Quality Improvement, to introduce today's speaker. Kate?
Thanks, Larissa. Can you hear me okay?
Yes.
Yep, loud and clear.
Great. Susan Nevada is a certified neuroscience registered nurse at Memorial Hermann Texas Medical Center, a comprehensive stroke center in Houston. She has been a nurse for 23 years with experience in several different neuroscience service line areas, including 15 years of neurocritical care experience at a Level 1 trauma center and coordinating stroke care at a comprehensive stroke center. In addition, Susan initiated a stroke program and attained Joint Commission Advanced Primary Stroke Certification for a regional medical center. She served as an expert panelist in developing the matrix for the stroke certification examination for the American Board of Neuroscience Nursing. And so it is my pleasure to hand it over now to Susan.
Oh, good afternoon, everyone. Thank you for joining us. We're going to be talking today, let me see where, you know what, I don't have control over my slides.
You should have, go for it, try again.
All right. No, not yet. I did have control, but it's not coming up now.
It's given back to you, so try it. There you go.
Okay, I have no financial disclosures to foreclose. And we're going to look, it's gone again. Oh, I don't have control. There we go. Okay, what we're going to look at today is where we are today. What we know is that worldwide, stroke is the second leading cause of death. In the USA, it is now the fourth cause. Up until a few years ago, stroke used to be the third cause, but because of the advent of comprehensive stroke centers and what we're doing in the world of stroke, we have actually decreased that to now being the fourth cause. But it still remains the leading cause of disability in the United States. With stroke approximately occurring 25% higher in men than women, and 80% of those of strokes that occur in women are actually SAH, subarachnoid hemorrhage. Key messages about stroke. We know that hypertension is a silent killer and often goes undiagnosed. Therefore, hypertension is the most important risk factor, and it contributes for about 50% of all strokes. Fatality in stroke is higher in men at 7%, and 10% of death occurs in women. The reason why it's more higher in women is because when stroke strikes women, it's usually because women are out at an older age, and therefore it usually ends like in morbidity or mortality. For every 1,000 patients who receive thrombolysis, 80 will live independently. Okay, incidence of stroke. Good news is that stroke incidence has decreased by about 18% in men and 24% in women between 1995 and 96, 2003 and 2004. And I believe this is due to the advent of TPA, which was approved by the FDA in 1996, and because of the advent of stroke centers. Rates have also halved over the last 20 years. But ominously, approximately 25% of strokes occur in people under the age of 65 years of age. And we're going to examine that population a little more closely. Survival rates. 10% of stroke victims recover almost completely. 25% victims recover with minor impairments. And we're going to explore that a little bit more, especially when these impairments involve the young and the middle-aged adult population. 40% of stroke victims experience moderate to severe impairments requiring special care, and 10% of stroke victims require a nursing home or LTAC. Looking at gender, comparing whites and blacks, the death rate in white males is lower than it is in black males, and the occurrence of stroke occurs higher in black males and higher in females. The reason for that, I believe, is that hypertension is more relevant in the black races, and it is therefore like a silent killer, often goes undiagnosed. And that could be, which is why this stroke may be more prevalent and why there's a higher death rate.
Sorry to interrupt you, Susan, but can everyone make sure your lines are on mute with *6? We're getting some background noise.
Okay? Treatment time and TPA. The NINS trial, which was the initial trial, or the initial stroke trial that looked at TPA for the efficacy, demonstrated beneficial treatment times within 3 hours of symptom onset. And then after that, we had the ECAS study, and that was a study that came out of Europe. And what that did is it looked at expanding that window, and it demonstrated that there is no increased risk of bleeding when you administer TPA in the 3 to 4 and a half hour window. Open the window for patients to be treated who arrive late in their onset of stroke. But however, there was another analysis, another study that looked at 6 large randomized control trials, and what they or what came out of that was that it was indicated that the optimal administration time for TPA is within 90 minutes of symptom onset. So we do know that the earlier patients receive TPA, the better the outcome. So the bottom take-home message here is that time is brain. Looking at some of the Get With The Guidelines data, we have charts here that show the comparison of TPA in the 3 versus the 4.5 hour window for all Texas hospitals. 2008 to 2013. And what we see that in 2008, in the 3 hour window, it steadily climbed with in 2013 being 86%. But however, when we compare that with the 4.5 hour window, we see that in 2013 that window has also climbed. And we have to examine the reasons why that has jumped so high. Is it because that when patients arrive in the ER that there's a delay in the TPA to treatment because physicians are really relying on that 4.5 hour window? Or is it that people in the community are still coming late to the ER in their presentation? If you look at the arrival note 2, and this is another slide from Get With The Guidelines, and we note that EMS usage in 2008 was really high at 68%, with it slowly decreasing down. And then when we look at the private sector with the private transportation, we see that is still high. So we kind of have to examine why the usage of EMS is also going down. And I have some theories on that in my other slides. So why does delay in treatment still exist? Well, we know that there are 3 delay phases. The first delay phase is a symptom onset to the decision to seek medical attention. Is there a wait time because patients don't think that stroke is serious enough, or because it's mild, or because it doesn't hurt? Then you have a delay phase from the decision to seek medical attention to the first medical contact, and this occurs, I believe, is when patients have signs and symptoms of stroke, don't readily seek the ER because maybe they have a physician appointment that day, so they're going to see their attending, and then they went to the ER via that route. Or from the first medical contact to hospital arrival, and that would be like EMS versus walk-in. The longest phase of delay continues to be the time from symptom recognition to the decision to seek care. The reasons for delays is that there's failure to recognize stroke symptoms. 62 to 95% of EMS calls are made by family, friends, or bystanders. And this is and you have to really think what percentage lies there of strokes that are actually witnessed versus found. There is also failure to activate EMS when the symptoms are mild because they felt it wasn't emergent, because patients feel it wasn't emergent, or else they'll drive themselves because they feel it's not emergent. And then the lack of pain. They're waiting to see if the signs and symptoms resolve. Or are they elderly, live alone, or they're home alone, and then they have a stroke, and they're unable to activate alterations or motor or visual alterations. And enough in the rural areas, in the backwoods areas, some areas are not well supported by 911.
Again, just a reminder, if you can mute your lines with *6 to cut down the background noise, that'd be appreciated.
Okay, so that in-hospital TPA treatment delays. The tradition when people walk into the ER is that you always get the workup and lab draws. And this is a tradition of cardiac workup. And it's usually a cultural knowledge deficit. When people come in, this is the first thing we do because this is what we've always done. Versus working an acute stroke workup, your protocol is a little bit different. You want to get them to the CAT scan early and faster. The second hospital treatment delay could be the hesitancy of physicians to administer TPA before a coagulation panel is resulted. Regardless, that the literature out there supports giving TPA without results, without your PT-INR results, if the patient is not on any anticoagulation. I don't know if a lot of people know this, but the half-life of TPA is about 15 minutes. So that's kind of where that, came in, that support came in. And then you have when Genentech, who is the marketer of TPA, of tissue plasminogen activator, when they first came out with the initial guidelines from NINS, they recommended that TPA not be given with an NIH less than 4, or if they have of an age of less than 83. And again, if emergency physicians aren't really comfortable with TPA, they kind of fall in these guidelines. But the NIH in no way is guide the decision for treatment, because a patient can come in with an NIH of 2 and have a devastating stroke in one of their speech areas. And if we don't treat it, that's going to evolve. And then again, you have physicians afraid of lawsuits. But there is literature out there that is counterintuitive to that, and physicians are actually being sued if TPA is not offered. And then you have walk-in strokes, have longer in-hospital times versus patient who arrives by EMS, or you have the failure of triage to recognize stroke. So, next slide, hold on. So EMS sensitivity to stroke. Sometimes you do have failure of EMS personnel to recognize stroke risk and occurrence. And the challenge is to partner with our community EMS to educate our EMS personnel to recognize stroke. On average, each EMS provider encounters between 4 to 10 strokes per year, and this is especially true in the rural areas. And then what even makes it more challenging is to really keep their stroke expertise up is that there's a high turnover among EMS personnel that makes repeated training necessary. And plus, rural area EMS may be volunteers and not on a paid basis. And then you have the failure of EMS dispatch to prioritize stroke. We have a critical pre-hospital interval, which is the time from dispatch to the scene. When an EMS dispatcher codes a patient, often codes a stroke patient, they respond it as less than a code 3. And less than a code 3 means they don't get lights or sirens. There are only 31% to 52% of stroke calls that are accurately identified. And that's because stroke has symptoms in common with other clinical conditions that lead to confusion of the call. So our challenge is to educate our EMS dispatchers. And what we can do is dispatcher recognition could be improved by examining specific words and phrases and then developing an algorithm. So if they hear stroke, facial droop, weakness, fall, and impaired communication, they can quickly put that flag up and think stroke. And then they can quickly have an algorithm down and see if the onset is acute or is it gradual. The 5 most common symptoms mentioned by the caller are altered mental status, trouble walking, impaired speech, abnormal breathing, and falling or dizziness. Only stroke is specifically mentioned in 45% of calls. And that's because in the community, if people are having a stroke, they may or may not know what the signs and symptoms are, but they're kind of like in that denial. They're afraid to admit that they have a stroke because with stroke is that tag, that stigma of disability. So interventions to reduce pre-hospital delay in stroke, some future directions. We have 4 challenges. And the first one is to address and understand the social, cognitive, and emotional factors that contribute to delay, and especially focusing in on the previously understudied and underserved populations. We need to understand why they delay activating EMS. Is it financial or is it their health beliefs? And then we can, after we study that, we can develop and test new interventions that target these high-risk populations. And then out of that outcome, we can systematically apply the effective interventions to date to educate all those patients at risk. Systematic application, what is known? We do know that messages of benefit versus fear-based messages have shown to be more effective. When we educate the community, I think we're sending like fear-based messages. If you don't get to the hospital within 3 hours, we can't give you a TPA, so therefore you're going to have this devastating stroke. Because fear breeds fear. So when they hear or when we educate the community with that, they're more hesitant to maybe activate because they're in denial or afraid that this is going to happen to them. If we emphasize urgency in immediate EMS transport and treatment within the context of benefit, they may be more inclined to activate EMS. And we also need to emphasize the benefit of helping patients make that 911 call rather than providing transportation. And this is especially true I don't have control. And this is especially true when we educate the public. In the Black population, they recognize strokes less readily than whites. They delay longer in seeking treatment, and they're less likely to activate EMS, and they have a greater risk of death. So we need efforts to improve awareness of the signs and symptoms in this population. We need to teach the families how to manage the social, cognitive, and emotional manifestations that accompany the symptoms to contributing to delay in our Black population. In women, Mortality occurs in 52% of older women before the EMS arrives. And why is because health providers don't appreciate the risk in women, and women are not as convinced that they are at risk. So again, we need to target our education efforts in public campaigns to emphasize this risk in women, just like women had that risk emphasized in cardiac. We need to do that for stroke. And we need to target it at the workforce as well. If a patient experiences a stroke at work, they are less likely to call EMS and more inclined to give their coworker a ride to the ER. So EMS is only activated for 38% of stroke cases at work sites. So we need education targeted at work sites to increase public education on symptom awareness and urgency to activate the EMS. So looking at the stroke in the young and to middle-aged adults, the recognition and management of stroke in the 18 to 44-year-olds. 532,000 to 852,000 people have had a stroke in this age population. This is twice the prevalence of MS, and with the African American incidence being twofold higher for ischemic strokes. And what really is the take-home message here is that in this population there was a high incidence of modifiable risk factors that could have been controlled. So when stroke strikes this age in this population, they have social issues that we need to explore because they have a longer survival when compared to the elderly. They have significant stress related to primary responsibility for their income and child care, so they have very different issues. Also, they have a high functional independence, and they have a high rate of post-stroke depression, and that's because they don't feel like they did. They have a high sense of fatigue, and 23% of this population that return to work require adjustment. We need more research to study what the other social consequences are, like what is the stress and the impact on their family and their role position within the family. Delays in this population is that they're less likely to activate 911 because, for one...
Again, everyone, can you place your lines on mute with *6?
Okay. Because they do not appreciate the stroke. The ER delays are attributed to misdiagnosis. For instance, posterior stroke syndromes are very hard to recognize, or they could be misdiagnosed or for a stroke mimic. And plus, stroke is still considered a disease of the elderly. So the caveat here is that if you have a patient who presents with stroke in the young to middle-aged adult, an early MRI can reduce the rate of misdiagnosis with a diffusion-weighted imaging, which only takes about 5 to 10 minutes if your physician is really on the fence about whether to treat or not. Another caveat here is that young patients with stroke, including mimics, treated with thrombolytics do not have an increased risk of ICH. And here at the medical center, Dr. Grada and his colleagues did a research study, a retrospective research study, and a prospective research study on stroke mimics. And their protocol insisted that anyone who presented within the window, and regardless of what their NIH was, that they would receive TPA. So afterwards, looking back at the data and analyzing the data, what they found was that TPA that was given in mimics with low NIHs did not have any hemorrhage rates. And there was a lower hemorrhage rate in people who did have a stroke, but who did not have a lot of comorbidities and whose NIH was lower. Your stroke risk comes when you have an elderly patient who has a lot of comorbidities and a higher NIH. Those are the ones who are really at stroke really at risk for hemorrhage. But when you weigh the risks and the benefits, if you have a good high-functioning 83-year-old who presents with stroke, would you or would you not give them TPA if they didn't have a lot of comorbidities? It's been my experience that we have treated this population and they've done very well, so you really can't deny them the TPA just on their age alone. So raising awareness, we can raise that through social media networking. You can do World Stroke Day runs, walks, family events, workplace information about stroke risk. I did a number of health fairs for employment places, especially with distribution centers, and it was alarming how many people there do not see a primary care physician, but yet and all had a lot of risk factors and a lot of high blood pressure that I detected. So I think like getting out to that community is essential. And also raising awareness in schools. We need to hit that younger population, teach them about stroke so they in turn can go home and teach their families, their parents, their aunts, their uncles. So future directions in promoting self-efficacy. This is always the challenge because we arm our patients with the knowledge when they have stroke, and then we send them out to the community and never follow up. And sometimes they become complacent. They're in the hospital, they get their wake-up call. They go home, they become complacent, and then they become frequent flyers. We need to prevent subsequent stroke by finding ways to promote and sustain those appropriate behaviors. And educational intervention is paramount to equip those at risk, to develop self-care strategies for secondary stroke prevention. So I found a research study, and I found it pretty interesting, and I think this could be a new trend in stroke, and it was a community-based stroke prevention program for clients with minor stroke. And it was a quasi-experimental study. It was done in China, and their goal was to improve knowledge about stroke, improve self-health monitoring, blood pressure, glucose, knowing what your numbers are in your labs, and maintain behavioral changes in adopting a healthy lifestyle for stroke prevention. So what it looked like is that it had they enrolled 190 subjects, which are randomized to either an intervention group or a control group. And in the intervention group, it was nurse-led, which focused on modifiable risk factors. And it consisted of 8 weeks, 2-hour sessions. And data was obtained at 3 time points, at their baseline, into 1 week, and then into 3 months. The data collection consisted of a structured questionnaire. It had 4 sections: their demographic profile, their lifestyle habits that included like their smoking, their drinking, their eating preferences, did they exercise, dietary habits, and self-monitoring, and then medication compliance and also stroke knowledge. Specific components of the data questionnaire focused on medication compliance scale, self-reported questions to determine cigarette and alcohol use. And when they looked at the cigarette and alcohol use, the subjects were asked to respond on a nominal scale. And you know, like how many times the patients come in here and they admit that they smoke or they have a glass of wine, and then the family comes in there like saying, oh, no, he drinks more, or they smoke a lot more than that or drink a lot more than that. It also focused on exercise scale to assess exercise patterns, the type and frequency of activity that was used on an ordinal scale. And they had self-reported dietary assessments, where they did a 2-week diary of type and frequency of food, and special attention to cooking methods, processed foods, eating times, extra servings, etc. Then what they did is the intervention was the 8-hour, 2-hour session held each week. In each session, there was 10 to 12 participants. Each session opened with 15 minutes of experience sharing. Each session closed with the word of commitment from each participant. So the participants actually did work. They identified a goal that they wanted to set and work on, And then they they identified interventions on how to carry out that goal and then reported out the next week. And if they had trouble following it or whatever, then the rest of the group came to their support and helped them with new directions or with new directions on how to meet that goal. So, and then what they did is they set the practical short-term goals, identified actions to attain those goals, and then they had personal log sheets and pedometers. So it's an easily employed nurse-led community program. And then in the subsequent weeks, participants reported out if the goals had been attained, they got feedback, and they had experience sharing. The control group, on the other hand, just received the conventional treatment. They had health promotion pamphlets on stroke and stroke prevention. Both groups continued to be exposed to the routine treatments, the casual information from health care professionals, the mass, and the media. The outcomes is that it proved to be statistically significant improvement in the intervention group. Knowledge, stroke signs, and emergency treatment response, health maintenance and behaviors, including medication compliance and daily self-BP and record keeping, and improved dietary habits. No significant changes were found in the control group, so it did have some efficacy. And this is the study, if anybody wants to look that up and see what that's about and try and get that up and running in your own institutions. And is there any other questions?
If y'all have any questions, you can unmute your lines with *6. No questions for our speaker today? *6 to unmute your lines if you have any questions or comments. I think I scared everyone and muted them. Sorry, guys.
Is it possible to get the slide set?
Yes, the slide set will be emailed to everyone within a week. I'll send a slide set. We also offer a certificate of participation, just so you can show anyone that you report to that you took time to participate in the webinar, and that will all be sent to you within a week of today, along with the audio recording if you would like to re-listen to the webinar or have any staff members who weren't able to attend. You can send them to that also. Right now, the slide that's showing is the contact information for the quality improvement staff. So if you have any questions, comments, anything you would like to see on these webinars, feel free to reach out to any of these staff members. Again, this will be part of the packet that's emailed later on, too. We will be posting, again, all of these slides and the certificate of participation on the website, heart.org/SWA quality. To ensure that only the participants who view the webinar can get to the certificate of participation, it's password protected, and the password will be stroke and the number 3, so you can view that. Any questions for today's presenter?
I would mention, this is Cherie Boxberger, American Heart Association, that there are many resources since May is Stroke Community Education. Go to strokeassociation.org. Lots of things you can download off there to use during the month of May to help with your community education. And not just in May, they're there all year long.
Any other questions or comments? Well, thank you all so much. We appreciate you taking the time to join us today and look forward to the email with all of the PowerPoints and certificate of participation. Thank you so much.